So it's the Prevail clinical data, and the Prevail balloons, I mean, basically are really very good investigated. So we came up from bifurcation lesions, multivessel disease. Now we approach more and more chronic total occlusion, diabetic patients, and some of us are already treating acute coronary syndrome with those kind of new therapy and drug-eluting balloons. And yeah, we have three big investigations there, and one is the Prevail Global study, which is running, the EBC DCB trial, and we have a lot of data from the SCAAR registry. So David already addressed the EBC DCB trial, and basically we see one-to-one randomization, 750 patients, and it's a non-inferiority. But please look at that. We are observing the patients up to 8 years, so it will be very, very interesting to see how it turns out in the long term. And it's a bifurcation-oriented composite endpoint. So now we go a little bit more into the SCAAR registry. So SCAAR looked at the safety and efficiency of Prevail DCB versus competitive drug-eluting balloons. So just if it's just safe, right? And there are 6,488 patients, and around 1,800 got the DCB from the Prevail MEDTRONIC arm. And there were very low event rates. So all-cause mortality was quite low in the follow-up. The event rates at 1 and 2 years were very good. And when you look a little bit more in the adjusted heart rate ratio, there might be a little bit of trend that the Prevail favors bifurcation treatment, even though there are very large confidence interval. It's only a trend, but at least it's not a downside probably to use a Prevail in bifurcation. So therefore we are happy that we have this device for our trial. So we already addressed the different strategies. How should we deal with DCB when we have a bifurcation to treat? Nobody was talking about a simultaneous bifurcation DCB treatment. Maybe we would have a good effect on the proximal vessel wall, but that's also an idea that we can focus on in future. So 23% of the SCAAR patients had bifurcations. And you see here 460 versus 1,000 patients which are compared. And those are the baseline characteristics. So well, not that high diabetes like in Malaysia, but 27% around had diabetes. And the lesions are not simple lesions. B2 and C lesions are in 60% in the SCAAR registry. And you see those are a lot of true bifurcations here when you look, 80% are true bifurcations. And well, the outcome was quite good for the Prevail balloon, 2.3% new myocardial infarction, so low infarction rate, low event rates. So it goes across all the registry, low TLR rates, zero defined thrombosis, acute thrombosis, which is also very important. Yeah, so there's been seen low TLR rates with the Prevail DCB across the subgroups regarding bifurcations, and also when you focus on bifurcations treated with DCB only compared to bifurcations with hybrid PCI. So it is a safe balloon, and I show you some examples. Some of you who were in Amsterdam maybe have seen that already. I'm sorry for that. But I think there are very good examples to see how we dealing with drug-eluting balloons nowadays. This is an acute coronary syndrome, and yeah, we put a stent proximal, but then you have this disease, diffuse disease and slow flow, so probably just leave it, or when you treat it, how should you treat it? So we decided to treat that with scoring angioplasty and do some 2 DCBs in kissing technique. Here you got it, and that was the result, how we leave the patient. So not perfect, right? But in the 9 months follow-up, it's getting to be almost perfect. So something is going on. That's a quite routine thing. Please do not over-treat those vessels in the acute setting. Yeah, you can combine it with rotablation as well. This was several times addressed by other hospitals with angioplasty, whatever, but it didn't work. So we rotablate the plaque there, and you see that nice result. Then 2 DCBs, again, kissing technique, 2 Prevails, and that's the post-procedure result, which is quite good. And well, we had the burr on shelf. The patient has instable angina, and yeah, we rotablate this as well, put an NC balloon, and finally a DCB. Yeah, it gives a lot of side branches which might cause angina, right? You don't know where the angina is coming from in those multivessel patients. So this is the 12-month follow-up, as you see here. Beautiful after rota and DCB in a bifurcational lesion. And here as well, it's quite okay, right, for having this 2 side branches and septal branches to the LAD down. So there's a graft on the LAD as well. Patient was asymptomatic. I left that like it is. So there are also hybrid concepts, as you can see here. That also makes sense when you have a large vessel, a lot of calcium, and well, here you see a burr going down, and then we put a stent after perfect plaque modification. And this, so there's still a bifurcation, which was treated with a DCB. This is a nice primary result. And the patient had as well a CTO of the LAD going down there, and there's already a stent from the main branch of the LAD towards the diagonal branch. Was treated with a DCB, and the patient was brought back. After 6 months follow-up, you see the stent is doing good, the DCB is doing good, the hybrid concept worked, and as well, the DCB in the LAD is doing well. Patient was asymptomatic. You see there's still a tight stenosis in the distal LAD, but as far as asymptomatic, we don't treat that. And now I want a little bit to go to a hypothetical, let's say, treatment therapy, which I observed in the last years. It's really a deferred stenting in cases where I already know that the stent might fail. So this patient is interesting because I treated him the first time in March 2023, and you see he had a lot of angina. So unfortunately, I could not get into the true lumen only very, very distally in the circ, right? So I only DCB'd that proximal part, and I keep the patient conservatively, but it didn't work well. After 5 months, he came back, and what you see is an instant restenosis and outflow of the stent in the main branch, but you see that there was some vascular healing there in the circ. So this circ is not feasible for surgical approach. We talk to the surgeon as well, so we treat that as well. Again, so open NC was put in the main branch, and we did 2 a DCB kissing there and get the patient off the table. And you see that huge calcified nodule on the circ ostium. And the first time when we crossed that subintimally, so around the nodule, so we couldn't get through the calcium when we opened the vessel. And when you go there with aggressive plaque modification, your first procedure, you might have a rupture there. That's not an easy task on a bifurcation. So I kept on following the patient up. After 22 months, I had to do again an angio based on persistent angina. And at that time, the vascular structure was completely healed. We saw a new intima and media, and the stent also was covered completely with intima. So now I could treat that vessel, which was an extra plaque crossing in the CTO, like an intraplaque crossing with a calcified nodule. So I rotablate that, and you see the result after rotablation. So I shockwave it, and I put even an open NC there, and that was the result. And now the patient, at least this year, he's symptom-free. I follow him up in my outpatient unit, and this is how we do defer stenting and defer plaque modification in patients where we cross subintima, where we cannot achieve a perfect plaque modification result. So, well, I think the key takeaways is that, first of all, we are really happy that MEDTRONIC is sponsoring this EBC DCB trial. It's a very, very important trial. I think we have a good device for that as well, proven on many, many registries, and the SCAAR registry seems to be very safe for bifurcation as well. And yeah, let's see what the data are. going to be in future. Thank you very much.